Hello, everybody. My name is Kurt Barnhart. I'm the editor-in-chief for Fertility and Sterility, and it is my pleasure to travel here to be part of Aspire to introduce a Fertility and Sterility-sponsored Journal Club Global. We envisioned these Journal Club Globals a few years ago to be able to highlight papers in fertility and sterility and highlight local authors and highlight the quality of the science that's done across the world and give our authors and experts a chance to talk about that. So these Journal Club Globals I enjoy because it's a combination of talking about the science, but then a really good conversation about where it can take us and how we can collaborate together. This one I think I'm going to be very much enjoying because we're really not only talking about the science, but we're really talking about what are the recent RCTs in the Asia Pacific region, how do we improve the quality, which is hard because they're already good quality, and how do we use this as an example to increase the amount of really good evidence-based research out of this region and the region in general. So I'm going to hand it over to my co-chair, Claire, it was wonderful putting this together, and I look forward to this. So thank you very much.
Thank you, it's a great honour. I'm going to introduce our live panel first. We have Professor Ben Moll from Australia and Professor Richard Paulson from USA, and we have Dr. Ho Man Tuong from Vietnam. But we're going to begin with our virtual speaker, and we're very grateful to you, Professor Zi-Jiang Chen, for giving some time to us. And we have about, you probably can't see us, Professor Chen, but we've got about 80 people in the room, and of course this session is being recorded, so the audience is potentially exponential. But I'd like to invite you first to speak about your recent publication and its underpinning publication in the recent publication in Fertility and Sterility and its underpinning primary publication in the New England Journal of Medicine. So could you please begin your presentation? Welcome.
Okay, thank you. Can you hear me?
Yes, we can. Yeah, it's great. We can hear you.
Okay, thank you. Thank you for your invitation, and thank the organization, and thanks to the President of TCV. I'm happy to see you, Professor Barnhart, and also other professors, old friends, Ben Moore, Paulson, and Tom. So it's my pleasure to participate in this fabulous panel discussion. So we are going to discussion about what are the recent RCT in the Asia Pacific region. Can I show? Oh, I'm sorry. I cannot show my PPT. I'm sorry. We need a call.
Can you show the PPT? Are we using Zoom?
If no PPT, I just. Oh, I'm sorry.
Are we using Zoom? Yeah. Can you just share your screen?
Cannot. Don't know what's wrong.
Maybe describe it for us, Prof. Chen. Would that be okay?
Yeah, okay. I describe, sorry.
It's okay.
I'm from a Reproductive Medical Center from Shandong University in China. So I would like to introduce the two RCT and the secondary analysis from this RCT we published this year in Fertility and Sterility. We know in recent years, single embryo transfer has been widely adopted in clinical practice. The best embryo for the first transfer has been widely sought. Embryo aneuploidy is considered to be associated with the implantation failure and miscarriage. So PGT for aneuploidy screening is commonly used in clinic. However, compared with conventional IVF, whether PGT-A could improve the pregnancy outcome, especially in terms of accumulated live birth rate, is unclear before we conduct our RCT data. So we conducted the multiple center RCT in 14 reproductive centers in China. At a total 1,212 fertile women aged between 20 and 37 years, 7 years old. The primary outcome of this RTT was accumulated live birth rate that resulted from up to 3 embryo transfer. So in PGT group, the embryo was selected by the aneuploidy with the NGS. In IVF group, we just use the common lab technique by morphology. Our results show the accumulated live birth rate was lower in PGT-A group than the IVF group. The risk of accumulated clinical pregnancy loss was significantly lower in PGT-A group than the conventional IVF group. So it was conducted that the conventional IVF treatment was inferior to PGT-A and resulted in a higher accumulated live birth rate in women with a good prognosis of live birth. So that's what published in the New England Journal in 2021. And as a comment in the editorial in the same issue, we are learned that for the PGT-A trials was responsible innovation. Innovation requires novel potential risk reproductive technology be the subject of careful research. After the publication of primary study, we performed a secondary analysis to invest the variation in pregnancy outcome between PGT-A and conventional IVF treatment across distinct groups, categorized by the oocyte counts. Participants were divided into 2 subgroups based on the quantity of the number of the oocyte retrieval. Among each group, the pregnancy outcome were compared with the PGT and the conventional IVF we did. We found that there was an interaction between whether the performed PGT-A, the oocyte number catalog on the accumulated clinical pregnancy loss. The PGT-A group had a lower accumulated pregnancy of clinical pregnancy loss compared with the IVF group when the number of oocyte retrieved was less than 15. So it was conducted that by this secondary analysis, we found that when the number of retrieval eggs was less than 15 of the PGT-A group, existed a lower accumulated clinical pregnancy loss rate, but no higher accumulated live birth rate compared with the conventional group. So this is the two publications. The first data published in New England Journal, and the second we published in Fertility and Sterility. Thank you very much.
Thank you very much for that synopsis.
I don't know why I compare PPT. I'm sorry, I can't compare the book.
That was perfect. That was terrific.
Can I ask our panel to make comment on this paper? You've all had a chance to have a look at it. Tuong, would you like to go first?
I read the paper. I saw that actually the study compare between the 2 screening method for selection embryo for transfer. The first one is morphology, and actually the second one is a combined method, morphology and PGT-A, not one by one, but one with 2. So the PGT-A group, actually they already screened the embryos by morphology first, and then they picked up the morphology based embryos, and then they do PGT. So actually in the PGT-A group, this is the combined method of embryo selection. And regarding to the number of eggs less than 15, maybe the group that have lower number of oocytes are the more age group. So they have a higher risk of aneuploidy. That's why we find better results and lower pregnancy loss rate with that group, with the PGT-A.
Thank you. That was a good explanation because I wanted to make clear why there was a secondary analysis. So the first study basically showed the non-inferiority of the two groups, or of the screening method. But one of the questions that remained was, are there groups of people where PGT-A is going to be more beneficial or less beneficial? And the surrogate marker that wasn't so clear was number of oocytes can result to the prognosis of the patient, because many are making the argument that the lower the prognosis of the patient, the more PGT-A might be helpful. Does that make sense, Rick? Did you want to comment on that?
Yes, well, thanks for that, Kurt. And I mean, I think the most important thing is this group should be congratulated for actually conducting a randomized clinical trial, which is so difficult to do in IVF, and the data are really unique, and they should be commended for that. Trying to do a subgroup that is slightly less good prognosis in this particular study is challenging. This was an extremely good prognosis group. There was less than 25% of the patients who had less than 15 oocytes. I mean, this was a great group. They had a follicle count of 22. The estradiol at the time of trigger was 5,900. I mean, this was a very good prognosis group. I would point out that the study asked the clinical question of non-inferiority and what they called a cumulative pregnancy rate. But what they really meant was the probability of pregnancy, first pregnancy, in up to 3 embryo transfers. That's not the same question as saying what is the cumulative pregnancy rate of all of the different embryos that are there. Because if you became pregnant after the first embryo transfer, of course you still had 2 more embryos left. And we are not taking into consideration the implantation potential of those 2 remaining embryos. And without getting too much into the weeds, the bottom line was that the pregnancy rate was essentially the same in both groups. It was a non-inferiority study, but the one group, I think the PGT-A was 77% after all of the embryos were transferred, and the standard group was 81.8, so very similar. I had a very hard time understanding how that was possible because, of course, PGT-A cannot have that low a loss rate. There must be a greater degree of damage from false positives in the embryo biopsy. And this is an artifact of a mathematical artifact of trying to look at how many embryos you need to get to that first pregnancy. This is not the same as the full implantation potential of the 2 groups, which I think is less in the PGT-A group. They just turned out that they happen to be equal. So those are the 2 points I wanted to make. This was an extremely good prognosis group. The 2 groups were very similar in terms of outcome, but remember, that does not mean that there was not damage that took place to the embryos from pre-implantation genetic testing, which there was, and there was probably a loss rate of somewhere. I tried to go through the numbers of probably around 15 to 20% in the PGT-A group of potential losses of implantation.
Ben, you want to make a comment?
Yeah, thank you. And first of all, thanks for being a member of this panel. I'm really privileged to sit here, and congratulations to Prof. Chen and her team to do this type of studies. I've worked in the Netherlands. I did multi-center trials there. I looked at Germany then, and I thought, are any Germans in the room, by the way? I thought, wow, if we could get Germany to randomize, we would be 5 times as strong. But China doing this study is 50 times as strong. So that is so incredibly important to do. That's the first thing I want to say, and I want to encourage Professor Chen. She's doing that, but I just want to underline it. Keep on doing these big studies because we need them. Then to the study itself, I think the strengths are the large sample size, and the second strength is the cumulative live birth rate. as compared to many studies that we have seen in this area that focus only on the first transfer. And if you're going to do embryo selection, of course, your first transfer is going to be better, and you think that the technique is actually better. But the key outcome for all of us in reproductive medicine is the cumulative live birth rate, right? The pain of infertility is lifelong. So we should really focus on getting the cumulative live birth rate as high as possible, and then maybe do it as quickly as possible and reduce pregnancy loss and the pain of that, but in that order. That's also the reason that the authors correctly choose a non-inferiority study. I've seen superiority studies for PGT-A, but any type of embryo selection is never going to increase the pregnancy rate. We should realize that. So superiority studies for embryo selection have a design issue in itself, and that's not happening here. Then I think it's very important to underline that if you read the New England conclusion, and I wrote that down, conventional IVF was non-inferior to PGT-A. So if you only looked at the last line, you think there was no difference or it was comparable, but it's not. It's 4.6% less, so to say. So that is really an important thing that we should consider in safety, and non-inferiority studies are difficult to interpret. I have had my battles also with journals who want you to write down these impossible non-inferiority sentences, but we should basically say it is 5% less. And then to the subgroup analysis in the Fertil Sterile paper, it's always good to look into subgroup analysis, but realize that because you go into subgroup analysis in 4 different groups, you lose statistical power. So the pregnancy loss in each of the subgroups is still there, but it doesn't reach statistical significance. And just by maybe coincidence, maybe there is a mechanism, the pregnancy loss rate is lower in one subgroup, but I would be very careful in translating that to clinical conclusion. It's useful to look in this data, it's good to have them presented in fertility sterility, but I would really go with the primary conclusion of the paper that PGT-A is reducing pregnancy loss a little bit, but it is doing harm also, in my opinion. And that is a very important conclusion that I have not seen from any study from the West. That's my first comment.
Thank you, Ben. One of the advantages of a Journal Club Global is we get to talk to the author. Apparently not at the very moment because the video cut out. But I'll ask the panel this question because I really want to ask Dr. Chen. One of the criticisms of this paper that's acknowledged in both papers is that they only biopsied the 3 best embryos and not the whole cohort. So I'm curious, your opinion, and hopefully Dr. Chen's, of how do you think that changes the results or helps us interpret this?
Well, as I said, the PGT group, actually they apply the combined method of choice, both morphological to pick up the 3 best, and then they do biopsy and PGT. That is a combined method. The thing is that because in the PGT-A group, they only use up 3 best embryos. So if there are aneuploidy or mosaic embryo, they will lose some embryos. In the other group, they can use up all 3 embryos based on the morphology. So the design will bear some kind of unequal between the 2 groups.
So let me ask the question slightly differently and let Rick and Ben decide too. How do we interpret this in that the practice usually would be to biopsy all embryos and have more available to you? So should we look at this as we expected a smaller difference because we only had 3 embryos biopsied, or we expected a larger difference, or how should we interpret this when we compare it to other studies?
So from a pure study design perspective, I thought the design was excellent. So you had to make sure before you randomize the patients that they had to have at least 3 blastocysts. So that's what they did. So there's a side effect of that, and that is that you've got this incredibly good prognosis group that is difficult to extrapolate the results from that to 40-plus-year-olds. But in terms of the study design, I thought all of that was very well done. I want to comment on something that Ben said just a second ago, and that was the final sentence of the New England Journal study, which said that it was non-inferior, and then he points out the difference that it's 3 or 4% different. I really think that that hugely understates the degree of damage that PGT-A does to embryos. And it is a mathematical byproduct of calling this a cumulative pregnancy rate. It's not really the total pregnancy potential of that cohort of embryos. It is how long did it take you to get to the first pregnancy. It ignores all of the embryos that are left over. And that's actually, that's my only beef with this study. My only beef with this study is that it underestimates the cost that you pay to get the benefit of the decreased miscarriage rate and the higher implantation rates with PGT-A. So I thought the study design was great.
So I'm going to direct this question at Ben, which is the same kind of question. I'm going to be the advocate of the devil here. Many of my colleagues say really all they want to achieve in an IVF cycle is getting to the first pregnancy as fast as they can, and that is the ultimate goal. And I know, Ben, you're going to say that's not the goal of the woman, but how do we reconcile this? Because our field wants to go towards the best, earliest outcome, which may not be, in my opinion, the best outcome.
So what was I going to say, you say?
I thought you were going to disagree with that.
Sorry?
I thought you would disagree with the premise I'm setting
Well,
up. That
it's not what I think. It's what our patients think here. And there is a very good study from the Netherlands, actually, in human reproduction, that asks patients, what do you think is more important? The number of embryos, the number of miscarriage, the time to pregnancy, or the cumulative live birth rate? And the scale of that result is such that they can hardly print it in human reproduction, right? So the importance of cumulative live birth rate is completely left, and all the other things are much less. And the reason that we all say to ourselves, no, it's about time to pregnancy and reducing recurrent that is bullshit, of course, right? It is the cumulative live birth rate, and if you say something, you probably have a conflict of interest with your own wallet. Let me be very clear here, right? It is the cumulative live birth rate that counts. Let me give many of us, if they're obstetricians, they're also have been on a labor ward, right? So if you're on a labor ward and there is a multiparous woman who has 6 or 7 centimeters disclosure, then she says, I want to deliver now, do a cesarean, etc. But you know that this woman is going to deliver in 15 or 30 minutes from now. So it's your professional obligation, so to say, to coach and mentor that women through it. And similarly, we have to say to infertile patients in their own interest, it is about the cumulative live birth rate. So I'm sorry, it might be a little bit longer.
So I'm just going to summarize that the very important discussion we just had is that there is a debate, is I guess a kind word, to what is the right outcome when you're using PGT-A. That a lot of the literature is pointing to first transfer, success immediate, time to pregnancy, and Dr. Mole and many of us are making an argument that perhaps that's the wrong outcome, and this trial got closer to what is a patient-centered outcome, which is it's not just the first encounter that I'm worried about, it's the overall encounter and how many embryos I have. So that's the point I wanted to make, and I'm glad we made that both in the primary paper and also the secondary analysis. And I'm now going to take the chair's prerogative and change a little bit, because this topic was not only about this paper, but about trials in the region. And I really wanted to ask Dr. Tiang, you've also, your group has made some very significant contributions in this area. And I would love for you to describe a little bit them, but also say how you were able to succeed and conduct such well-conducted, important trials.
Actually, 10, 15 years ago, we decided to do clinical research as our kind of strategy. Because we found that it is the best. If we can do good clinical research, it is a good way for us to learn. and then we can have better practice when we do good clinical research. And also we can develop ourselves better. We have strong background of clinical research. So we decided to do. And we was a very young group, and we don't have that kind of strong academic background. So we decided to ask for help. So we go for collaboration with our friends and mentors who have a lot of experience with doing clinical trials. And we learn a lot. And that's how we can move quite rapidly during the past 10 years. And we provide some good trials and publish. I think that we should do clinical research and publish. And we can get the assistance and the help of our colleges and our professors from all over the world to help us. And I think in Asia Pacific, we have more IVF cycles in more than any other areas in the world. So we should contribute something to the data and the evidence in this field. This is what we have done.
Thank you. You mentioned that one of the barriers was expertise, and you found that overseas. Were there any barriers in recruitment? Because as I understand it, you don't have funded IVF in Vietnam. Is that right? Can you talk a little bit about that?
Actually, we have Vietnam. We have a lot of IVF cycles, and we now have more IVF cycles than any other countries in Southeast Asia. We can serve more patients. IVF is expensive, of course, but we can serve more patients because we can control quite well the costs of treatment for our patients. Even they have to pay their own pocket, so they will have more patients. And when we have more patients, the cost will be lower. And the patient, they believe in us, and we have more patients. We have numbers. And we have the prestige, and patients rely on us, our profession. And then when they ask them to join us for a trial, so many of them ready to join us. And that is why we have good recruitment rate, and we can provide good set of data from our practice.
As a clinician, when I read these trials, we have to make a decision about how extrapolatable the findings are to our own practices. Do you see any issues for that, Tuong and Rick and Ben? The extrapolatability of the findings to clinical practice. Can you speak about that, particularly for this paper that we're discussing today?
Well, I mean, you're always going to have a problem in that the recruitment is going to be specific to your patient population and your geographic area or whatever the other demographics are, which is why it's critical to have appropriate controls. And this was a randomized clinical trial that had randomization, and they were able to demonstrate that in fact the two groups were similar. So your point is well taken. How can we extrapolate from one ethnic group to another, and there may very well be differences. I worry more in the case of, for example, PGT-A and other fertility treatments is that we typically study the group that has the best possible outcome, because that's what gives you maximum power. It's a lot easier to demonstrate a difference between, I don't know, 40 and 60% than it is between 5 and 10%, where that would actually be a doubling, and yeah, you're going to need many more numbers. So we always look at the group that has the highest success rate in order to have study power, and then we go and we extrapolate. So I'm always worried, to bring the conversation back to PGT-A, is that all of our data are in these excellent prognosis patients. We don't have any idea whether a 41 or a 42-year-old patient, for example, can grow embryos to blastocysts in vitro, and how well those older blastocysts tolerate the biopsy procedure, and whether in fact the data that we get from the trophectoderm biopsy can be extrapolated to the rest of the embryo. So I worry more about extrapolation from a good prognosis group to the poor prognosis groups to whom is being applied, more so than I think within the different ethnic groups.
Yeah, I think one of the points I bring out here is that there are very specific questions in our practice that faces the patient I'm facing in front of me, the patients I see in Philadelphia, the patients that are 39 to 41 years old, the patients that I have trouble getting 1 or 2 blasts. That's a very different question, and I want to know the answer. I don't necessarily think I can get it from the experience in this, but what I can get from the experience of this is the true efficacy of the intervention. It might not tell me how to peak trace an A, but it'll tell me that PGT-A is or is not a benefit in general. And that, I think, is the benefit of the science. Not only this question, but the other questions you've done on ICSI or no ICSI, or fresh versus frozen. Those are still techniques that can be evaluated across the world and whatever the population is. And even the next question. I want to shift gears a little bit to say the value of doing a randomized trial, though. Because look what this spun off, right? Not only is a randomized trial giving us the best, most unbiased answer to that specific question, but it spun off secondary analysis in areas. It spun off collaborations with epigenetics between our colleagues. It spun off many other great collaborative science, and that's the kind of science we need for our field. And I want to again congratulate the studies that have been done in the Asia Pacific region, because they're very difficult to do in the United States and Europe now. Ben, you gave me an anecdote earlier today about, and mentioned it a little bit today, how difficult it is to a randomized trial in some of the more developed areas where I can't enroll people in a randomized trial, and you said you were having trouble yourself.
Yeah, I mean, that's a reality. The amount of paperwork that you have to do trials in the settings where I work in Australia, and also what I mean, the Netherlands, where I left 10 years ago, has had much more bureaucracy introduced also. That's a reality that luckily is not that stringent in Asia. And so if I talk to colleagues from Vietnam or China, they say to me, oh, we have a protocol and now we have to go to ethics, and that's going to take a long time, right? And then you see them worrying, and my goodness, so how long it's going to take? And then they say 6 weeks, right? They said, listen, in our setting, we take 6 months, right? Plus, and I honestly don't know how these studies are actually done, in terms of the budget also, there is no comparison in how efficient you do the studies, because you integrate them with your clinical care, you motivate your whole team to do that, you collect the data within your database. There are all kinds of factors that make these studies feasible. And yeah, in the West, we should really reconsider what we try to achieve with all our bureaucracy to keep the research as good and safe as possible.
Dr. Chiang, I was going to ask you, and also Dr. Chen, who unfortunately we've lost, can you give us a little example of how you were able to recruit so efficiently and so successfully? It would be, we could all learn from that.
Yeah. Usually we prepare very carefully the protocols, very in details, and we discuss in a group. We train a group of people. We have some good recruiter who can talk with patients, who can discuss, and who can convince, and who can explain to our patient. We have that group of people in our centers. So we discuss together very carefully before we start the recruitment. And actually, we have a privilege that because we are the quite a British group in Vietnam, and most of patients know that we are the best in Vietnam for that kind of treatment. And we have prestigious of professional activities, and we have names, and that make it easier for us to recruit patient, and patient rely to what we have done.
Professor Chen, it's lovely to have you back again. Can you hear us? Yes? We'd just like to ask you the same question that we've just asked Dr. Tuong, and that is, can you tell us about the barriers to recruitment? How do you manage to recruit such a large number of subjects? Can you take us through that, please?
Okay, thank you. Thank you. Also, thank you, Dr. Ben Moss, comments. Yeah, we actually, similar like Vietnam, my colleagues said, in China, we are a big population, and also I did several trials on the big sample size. I think it's very significant and for the clinical, for change practice. I think the RCT is very important for our practice in the clinic. In China, we have some benefit that we have big population. We have a lot of big centers for IVF centers. So when I organized this RCT, I based on our international colleagues, some friends help. We have an international DSB committee, DSB data safety committee, and we have a proposal committee. We have a steering committee. This big committee, and we have some international professors and experts involved and help us at the beginning. Now, when we started to do our research, we train center by center, phase by phase, how to recruit the patient, how to do the patient concern form and information form, and also we use the third independent database, the center. In China, we have all statistic data centers. So that is in the past more than 10 years, we completed more than 6 big trials. All of them is multiple centers. At the beginning, we are difficult, but getting better and better. Our doctors, many doctors, or more and more centers are interested in the clinical trial right now because they realize how important the trials, the clinical studies to help us to improve our clinical practice and how important for our guidelines or clinical consensus. Thank you.
So that's a very important message. I'm talking to 2 of the largest centers and most successful centers in Asia with these trials. I'm in awe at how you can do these so well. But there are many people listening in this audience and when they see this broadcast that might be interested in clinical trials. So I want to ask you both, you said training was important, but what advice do you have for the centers that want to start doing trials that was the most surprising to you or the most paramount to keep this data the integrity of this data so good and the quality so high? What can you share to the smaller clinics that are interested in doing trials?
I try to understand. I cannot hear clearly from you. Yeah. We have our course one by one, and we have class, and each center we have, some doctor. We have a group for study from, primary clinical doctors, nurses, assistant, and they get together and even then learn how to do case by case from beginning, how to talk with the case. From beginning, we have a center, we have different committees to do the quality control, and also we do site inspection one center by one center at the beginning. Then,
yeah.
I'm sorry because I cannot get you all. Cannot hear you clearly.
No, that answered it wonderfully. Dr. Tiong, what do you think was the largest barrier to your staff to do a randomized trial? Was it accepting the concept? Was it the idea of randomization? What needed to be overcome?
I think the thing is, the most important thing is that all staff in our clinic, in our hospital have to agree that we have to do it the right way. So if some people, some department, they do not have interest in that, and they don't want to do it like that, we will fail. So the most important thing that we have to agree in it's one of our culture that we have to do research and we have to do the right way. Actually, we had a lot of mistake at the beginning when we start. And Ben was with us from very beginning, and we learn, we improve from time to time. If the whole team decided to do and decided to improve, we will get there with the good help of our friends from experienced friends from many parts of the world.
And maybe add to that, the importance and the opportunity of this meeting is that it's actually 10 years ago that we were introduced to each other by Rob Norman at the Aspire meeting in Brisbane. And I would encourage everyone to reach out to people with expertise, because we're going to go to a setting where the expertise doesn't have to come from abroad or outside Asia anymore. It's just widely, I mean, you having done all these studies, the work of Professor Chen, other people in the room I see doing these studies, the expertise is here also. So if that could expand to other centers and they're going to, with that statistical power, bring that quality, that would be great. One other comment about interpretation of the studies and the fact that it's not applicable to your population. Let us not forget that the first law of medicine is first do no harm. So the obligation to show that something works is with every doctor that does these interventions. And I don't think that we have the luxury to say we deny the finding that PGT-A potentially harms or that ICSI is less than IVF, and therefore I continue to do my practice. If you say that, you have to do the study in your own setting. And if you're not doing that, you're potentially in conflict with Hippocrates. Chew a little bit on that.
So I want to just summarize. I asked two world experts here and conducting wonderful clinical trials in reproductive medicine, and they both told me the hardest part was to get the doctors to agree that a randomized trial was the right thing to do. I didn't hear that you had trouble just talking to the patients. Is that true? The patients, if your staff agreed it was the right thing to do, your patients agreed?
We have an advantage that most of our doctors, they came to us as fresh, and they are trained under the same roof. So we quite easily to work together and to start something. So we mostly have no problem to have a kind of consensus of doing something new. And as I said, that we have a group of assistants who help, because doctors sometimes we don't have enough time to discuss, to explain to our patients. So after we have a consensus between our doctors, we're working with that group of assistants. We will discuss what we're going to tell our patient, and what our assistant will tell to the patient. And when they come to doctors, so what we're going to add on that to explain and to convince our patient that they should join us in this trial. So we work together. As I said, that the most important thing that is the culture of the group. So we decided to do it, and we do it together.
We're a little bit short on time, so I'm going to ask everybody to give a final comment, and I'm going to start with Dr. Chen. Dr. Chen, congratulations again on all of your studies. Are you finding it harder or easier? And do you have any comment about this trial in general you want to share with us?
Oh, thank you. I don't think it's easier. It's still hard. If you want to get high quality trials to complete that, it's not easy. We have to work hard with one cases and complete one form, and we need to negotiate with patients. We need to get more trust for our patient, and also we need a good team, train the team to learn how to good quality trials. Thank you.
Why don't we go around the panel? I'm just looking at the end. Ben, why don't you give us a summary of what you think you learned from this session and some advice you can give about trials in this area?
Well, what I learned from this session is that it's very clear that these large RCTs, where in many areas of the world people say these studies are not possible, they are possible and they're done here. So I would encourage everyone to feel inspired by the leadership that we have seen from Vietnam and China here. See if you can achieve the same. And I want to congratulate, but at the same time, challenge, aspire, being a host of this to endorse this and to create a platform where these studies can continue to happen.
So my parting words will be to again congratulate Dr. Chen on her study and to tell you that I'm absolutely in awe of your database and of your ability to complete a study like this. And if I could try to convince you to go back and try to analyze the data to even a greater extent. So you answered the basic question of the cumulative pregnancy rate, but for those, I spent a lot of time going through that study trying to reverse engineer what the implantation rates were and how it must have been and how many transfers were in one group and how many transfers were in the other group. Can you reveal that? Can you go back and maybe publish another paper or two and extract it and say, this is what the implantation rate was in the first transfer, this is what the implantation rate was in the second and in the third, and how many transfers were there in the PGT-A group, given the fact that the euploidy rate was about 68 or 69%. So please satisfy some of us super curious math nerds who can't get enough of this kind of data. And congratulations again.
Thank you. Thank you for the suggestion.
So after more than 15 years doing this, we think that the one who benefit the most from our clinical trial is our patient who trust in it, who give trust in us, and our staff who can learn and do it the right way, the better way for our patients.
We're going to have to close this session. We're actually over time, but it has been very stimulating. I'm sure all of the audience will agree. And of course, there's going to be a virtual audience, which is probably going to be enormous. But I think 60% of the world's population live in Asia Pacific. And to see talented leaders like you harness that potential to study medical intervention, you are absolutely wonderful. And again, congratulations. And let us thank all our presenters, the investigators and our panelists, and of course, our visiting editor-in-chief from Fertility and Sterility. Thank you.
My pleasure, and I just want to again say thank you for attending a Journal Club Global by Fertility and Sterility. This will be cataloged online, both at the Fertility and Sterility website, as well as, I hope, Aspire as well. So please share the information, and I hope I'll see you again at another venue.